Good afternoon, everyone. Happy New Year. I can see the participants is quickly adding up. We had 40 people register for today's event, and that is really great that more and more people are joining us. If you could help spread the word, the second Thursday of every month, we'll be doing the speaker series. And today we have a great presentation for you. This presentation was actually the idea of the Human Trafficking Committee. They reached out last year to Dr. Janelle Potter at the University of Miami to come and speak at the club during one of our lunches. And so this was scheduled oh so long ago, and I'm glad that I could help make it sure that it happens even in our new norm. Just for the few of you, I am so grateful for coming in on time. There's probably people who haven't registered, and now there's 5 questions you have to answer to register. So I'm just going to ask everyone a single polling question. We're going to do 3 of them because there are 3 parts to the presentation. And for the first one, so in your knowledge or in your mind or what you've heard, what you think, Miami, Florida falls in which category for total human trafficking victims? Would it be in the top 50 cities worldwide? Or do you think Miami is within the top 10 or the top 3? You can answer what you think the answer is on your screen, and we'll just see what people know so far. But go ahead and put I'm going to close this in about 30 seconds. So go ahead and put your answer for question number 1. All right, super. Yes, most of you know, 78% of you know that it is in the top 3. Miami, Florida is number 3 globally for human trafficking. And human trafficking is big business. Second to drugs, but ahead of guns and illegal weapons. So, and that is globally. So we're going to learn a lot about human trafficking during this presentation, which was pre-recorded. And before I leave this screen, if you are familiar with Zoom and you can open up your chat box, why don't you say hi to everybody and let us know that you joined us by typing in your name and what your affiliation is and how you heard about us. Just say hi to everybody. And you can do that throughout the presentation. I am going to, everyone's holding their breath. Can Travis share the screen? Almost everybody is here. Just a couple more people. Hopefully they don't miss much. I'm so glad to see so many people saying hi and reconnecting. It's been a month, and a crazy month with election and holidays and throwing out of the old and starting new. And glad we're connecting again. So definitely, if you're experiencing any issues and you want to reach me, if you have my cell phone number, you can certainly text me. My ringer is off during presentation, but let me know and I'm happy to help walk you through it. You can also put it in the chat box, which is, record, but sure, tell everybody a hint or a pointer or something that could help somebody else figure out how to join us. It is 1:09. I'm a bit ahead, and there's still quite a few participants who haven't logged in yet. Madam President is having issues logging in, but she's trying to use her cell phone. It is easier on a desktop or laptop computer than it is on a mobile device. That is true. If you are using a mobile device and unsure on how to navigate Zoom on your cell phone, that is a common issue. You're not alone, but there are ways to work around it, and I can help you learn those. I can help navigate you through that if that's your situation. So just before I hit play, I want to remind everyone that Dr. Janelli Potter, who is the founder and executive director of the Thrive Clinic at the University of Miami and Jackson Memorial Hospital, she has brought a panel of speakers. So we'll be hearing from numerous individuals, but Dr. Potter is here with me at the clubhouse and is happy to answer any questions during the Q&A at the end of the pre-recorded presentation. All right, so I look forward to introducing everyone to Dr. Potter. So I am going to now start part one, and enjoy yourselves. And we'll have a question in between each part.
My name is Jonelli Fantis Potter, and I'm very grateful to have the opportunity to speak to you today about the Thrive program at the University of Miami Jackson Memorial Hospital. We've spent the last 6 or 7 years modifying and improving our healthcare model for survivors of human trafficking. And today I brought some of our experts in the field. I'm a nurse and a clinical professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences. I started my career at the University of Miami in the early 1980s when the HIV epidemic became apparent in South Florida. And over the past 40 years, I've spent my career working with populations of vulnerable women, learning about stigma and discrimination and the lack of access to health care and the chronic health care needs that many people live with in our community. We've had the opportunity to work with the state attorney's office and law enforcement, and we were brought into their policy meetings to look at what we could do to improve services for this community. And we said really what we needed was one clinic at Jackson Memorial Hospital, one space where the patients could come to that space regularly and feel safe and be comfortable in that space and know that they could return there and feel protected and cared for. Mr. Magoya, the CEO of Jackson Memorial Hospital and Jackson Health System, provided us that space. And over my years of working with Jackson, I had developed many relationships from some people that you're going to hear from today about their work in HIV and advocacy for women and vulnerable populations. We started to develop a model of care that would best serve these patients. We sat down with our partners at Jackson Health System, the people that did credit and classification, the nurses that ran the clinics. We brought law enforcement to the table. We brought Homeland Security to the table. And we started to talk about what this model should look like. We made a model of care that includes primary care, OBGYN services for the women, and the psychiatry team. They're the core providers for the Thrive model that come to see the patient in that same clinic every week. It creates a sense of stability and safeness for the patients, and they feel like they can relax and they know and are familiar with the environment. We also knew that we needed to find navigators, and so we had the opportunity to write a program grant to describe our model for Thrive. We sent an application to the Department of Justice Office of Victim Services, and although they were funding at the time mostly law enforcement programs, We were one of the first models in the country to design this type of healthcare that worked hand in hand with law enforcement to deliver care. The Thrive Clinic works with victims once they are identified, once they are removed from their trafficker and they're in a shelter in a place where they can feel safe. That's when the real work begins. Many of them have chief complaints. Some of them have headaches. Some of them have pelvic pain. Some of them want a GYN exam. Whatever it is that they want, that's where we start. That's what I call survivor care, right? So there's trauma-informed care, and we take it up a notch, and we do survivor-informed care. We listen to the patient, and we respond. These are people that haven't had health care for many, many years. We start with what they want, because we know over time, as we build trust, we'll eventually get to all of their health care. So the Department of Justice grant provided us funding so that we could hire a patient navigator and a social worker that would accompany the patient to the health center. Jackson Memorial Hospital Medical Center in downtown can be overwhelming for folks that don't have trust, who are scared, who have anxiety, or have been discriminated against. And so either the navigator or the social worker stay with the patient through the whole visit. The other problem that patients have is traveling to the health center. So we pay for a Lyft or an Uber to bring the patient in and bring them back home. They don't have to be afraid of traveling on public transportation or walking from the shelter, which could be a mile or so away, to the health center. These components make up the Thrive Clinic, and we've been very successful in helping our survivors re-engineer their lives. So we've spent the last 6 or 7 years modifying and improving our healthcare model for survivors of human trafficking. And today I brought some of our experts in the field. First, we're going to have Dr. Brooke Hensley, director of the Roxy Bolton Rape Treatment Center and one of the emergency department physicians, who will speak about her experience, what emergency departments can do to help identify and treat survivors of human trafficking or victims that may not yet be identified. We also have the pleasure of having Dr. Symes with us today. He's an associate professor in the Department of Medicine with a specialty in infectious disease. And through his experience of working with patients who are victims of crime and asylum victims and vulnerable populations and people with HIV, he was the ideal physician provider to help us establish a primary care model for our survivors. He's been working with our survivors in clinic to help address their multiple healthcare needs. This Thrive program did not happen in a vacuum. It takes a community to build a model of care like we have. And I could not have even started to imagine how we could have accomplished this without Dr. Pat Corrales and her years and years of work in domestic violence, both as a physician and a lawyer. So I'm very happy to have Dr. Pat Corrales to talk to you about what the future direction of Thrive is and what you can do to help prevent human trafficking from continuing in our community, in our country, and worldwide. Thank you for this opportunity. First, I'd like to introduce Dr. Brooke Hensley. Dr. Hensley, thank you so much for taking the time to talk about your work in the emergency department.
Thank you, Dr. Potter, for inviting me, giving me the opportunity to speak about this very important topic. I am Dr. Brooke Hensley. I grew up in Denver, Colorado, and I did an emergency medicine residency training at the University of California, San Francisco. And I went to Harvard, Massachusetts General Hospital for an emergency fellowship. And then after Boston, I moved down to Miami with my husband, and now I am emergency clinical ultrasound faculty at Jackson Memorial Hospital, as well as the medical director for the Roxy Bolton Rape Treatment Center. In the emergency department setting, it's where everyone goes for help. It doesn't matter who you are, how poor or rich you are, where your background is. And I like the emergency department for that reason, because we interface with the community in a very special way. Every interaction is an opportunity to help somebody, whether or not they're explicitly asking for help or you find opportunities to help them.
Dr. Hensley, what is the role of the emergency department in identifying human trafficking victims?
We know that 87 to 90% of survivors have reported accessing healthcare services during their trafficking situation. And of this, 68% were seen at an emergency department. And this is for various reasons. Many of the trafficking victims and survivors do not have access to a primary care provider. If you have nowhere to go for healthcare, you come to the emergency department. However, only 5% of emergency physicians have stated that they feel comfortable identifying and treating possible victims of human trafficking. So this quote is from a survivor, and this really struck me. No one ever asked me anything anytime I ever went to a clinic. This, I think, perfectly captures why I'm motivated to help and why I do what I do. What we know from speaking with survivors is that they go into these clinics and emergency departments, and they aren't just walking in self-identifying most of the time. They're there for various things, for pain, they have an infection, they're not feeling well, and it's a silent cry for help. And so we have to make the environment such that they feel comfortable, building rapport with us and accepting our help when we identify them.
Dr. Hensley, what would you say are some of the biggest barriers that you have in the emergency room to identify survivors of human trafficking?
You would think that if anybody were in this type of situation, whether or not it is human trafficking, domestic violence, interpersonal violence, they're in trouble with the law or drugs or whatever it may be, you think they would just walk into the emergency department and say, help me, I need help. And those are for various reasons. There's a lot of shame or guilt for people who are in these situations. They fear retaliation by their trafficker. Maybe their lives have been threatened. Maybe their families and their friends' lives have been threatened. If they are not U.S. citizens, there's fear of arrest or deportation. It's very complicated, and they feel really badly and embarrassed about it. They don't have control of their identity. And they don't understand how the U.S. healthcare system works. They don't know if they're going to get in trouble, if they're allowed to ask for help, or if that's the appropriate place to get help. This is just a list of common emergency department presentations. So how can I, as an emergency physician, teach my emergency department colleagues and residents and staff, how do we separate through all of this, but to see the person as a whole and see how we can identify human trafficking victims? What we do is we try to learn about red flags of human trafficking. They may not even realize that they're being victimized or being taken advantage of. It's not that every single person who comes in this way, they just may have truly an overprotective family member. So is it that, everyone who comes in trying to speak for the patient, is it because they're the trafficker or they're in a trafficking situation? No, these are just some red flags that you have to kind of take into consideration as a whole.
You mentioned that there are red flags, clues that you train workers in the emergency department to be aware of and explore. How do you determine what are the red flags versus natural characteristics of an overprotective mother or an overprotective significant other?
You have to dig a little bit deeper and read the situation to see if there's just something not right. When you speak to them, it seems scripted, memorized, like they've practiced what they're going to say. It doesn't quite add up. Or there's somebody there with them who may be even claiming to be their significant other or a family member or friend who is trying to speak for them and always cutting them off. The patient themselves are afraid to speak up on their own. When they have a companion with them in the emergency department, they seem overly attentive and they don't want to leave the patient's side. They are insisting on interpreting and being the mouthpiece for this person. And this may not be something that you may be aware of immediately in the emergency room, but when they register or they have to give documents, or you may have to ask them outright, do they have control of their own documents, their IDs, their money, their passport, and things like that? And the Thrive Clinic helped develop these screening tools that have been studied in the literature, and they've been shown to be more sensitive than a clinician gestalt, meaning, your kind of gut instinct, I think they're being trafficked, or I don't think they're being trafficked. These screening questions tend to capture more of those situations than just kind of having your own hunch, because they're kind of icebreakers, and they're not, once you develop rapport with them, you can kind of show that you care about them. So are you able to come and go as you please? Do they have a gatekeeper where they live? Where do they sleep and where do they eat? Another type of icebreaker you can try with the patient is, what type of work do you do? Do you have to meet a certain quota before you go home? Have you ever been forced to exchange sex for food or shelter? These questions try to capture not just sex trafficking, but labor trafficking, which is also a huge problem. And it's everywhere. It's not a question of, oh, if this is going on in my community. It is going on in our community. Sometimes you have no idea. It could be, restaurant staff that, they're sleeping in the back, or they've been working for weeks and months and not getting paid. A nanny of a very affluent family, and it seems like nothing is wrong. And, oh, that's nice, they can afford a nanny, but they've confiscated all of their documents. It's not just the stereotypical, what they kind of show in the movies of sex trafficking. So this is just an algorithm that I helped create for all emergency department staff, and this is going to go throughout the whole hospital, of what to do if you suspect human trafficking. And a big barrier to helping people is they think, who do I go to for help? Who do I report this to? Do I call the police? Am I obligated to call the police? What numbers do I call? And so this is a nice algorithm where there are phone numbers to the Thrive Clinic, to the Roxy Bolton Rape Treatment Center. There are phone numbers for the Human Trafficking Hotline and local law enforcement. Just some general pearls that we try to stick to with education and addressing human trafficking in the emergency department. You want to try to speak to the victim alone. Right now, during coronavirus, it's actually made it easier for us because we're not allowing visitors in the emergency department. And once you suspect something, you really want to educate the patient on their rights and what they can do for help. They may not be ready to accept help at that moment, but you can kind of have a frank conversation with them and say, listen, we're here to help you at any time you're ready to receive help. You want to respect them, respect their autonomy. You want to encourage them that they're not alone. Overall, education of staff is key. We're the second largest hospital in the United States, and I realized that nobody from the emergency department was involved with the Thrive Clinic. So when I met with Dr. Potter, it was so encouraging and inspiring, and I wanted to do my part and educate the next generation of physicians no matter where they decide to go practice. These patients are hiding in plain sight, and if you don't know the signs and the questions to ask, then they're going to continue hiding, and we're going to miss all these opportunities. I showed you the emergency department protocol. We're developing a mandatory triage screening tool that's in the works right now. And once we educate the staff, we're in the emergency department, we're going to go hospital-wide and then system-wide with Jackson North, Jackson South. Jackson West is opening soon. It's going to be integrated into their system. And we're going to be developing simulation training for the nursing staff, medical students, and the resident physicians.
Dr. Hensley, thank you so much for taking the time to meet with us today.
That concluded part one of the panelists that Dr. Potter invited to speak. Let's see if anybody in the chat box is, we have 32 people participating. Everyone is saying hi and where they're from. I did get 2 text messages from people who were having technical issues. I'm so sorry about that, especially if you're on a mobile device instead of a computer. I'm glad there's more people joining us. Welcome, everyone. I would like to ask everybody another quiz question. What is the average age that boys and girls enter into a trafficking situation? This is what we would call the interactive part of the presentation, making sure you're not just saying you're attending and then chatting on your phone, but actually hopefully learning some new stuff. And from, let's see, that's about half of you answered. I'll give it another 30 seconds. Almost all of you are correct. It is ages 11 and 12. And that's pretty early. That's really early. And then sometimes 20, 25 years later, just getting into care. I'm going to go to part 2, the next speaker on the panel. Please hold.
Dr. Symes, thank you for taking the time out of your very busy day to join us today to talk about your extraordinary work with our patients and the time that you spend with them to help them with their medical and their mental health needs, and what you do in the Thrive Clinic for our patient population.
Well, it's a real pleasure to be here today. The work that we do in Thrive Clinic, taking care of those who have been traumatized but have the resilience to rebound and move forward, is truly, for me, something special. Just a little bit about myself. My name is Symes. I grew up in Kingston, Jamaica, and I came to Miami to do my training in internal medicine. Immediately captivated by Jackson Memorial Hospital and what it meant to this community, a place where anyone could go for treatment and get the very best of care regardless of your background. That really inspired me, and this is the place I wanted to train, and this is the place I ended up learning about medicine, how to be a doctor. I also specialized in HIV care. This was in the midst of the HIV epidemic in the mid-80s, early 90s. I think my background in taking care of HIV patients, which was a real complex and continues to be a complex disease process, multidisciplinary. It really pulls together the need for individuals who can do primary care, understand infections and infectious etiology, but also understand trauma and the multiple social determinants of health, who can pull that together and really come up with a holistic approach to medical care, has helped me in this new field that I've been in for the last few years with human trafficking victims. Again, I'm really proud to be a part of that process in helping to deliver excellent care once we've gotten them into care. What I wanted to talk about in terms of primary care for human trafficking individuals is that when we look at individuals who've gone through multiple trauma, we realize that they have these multiple physical complaints. Over 80% of them have headaches, 70% of them have dizzy spells. Many, over 2/3, have memory problems. They have chronic complaints such as back pain. Most have fatigue. Up to 2/3 have various sexual health problems. So we're really talking about multiple physical health symptoms, and this can be missed or put out of context if you're not also addressing their psychological issues and you're not making sure that you build that into your plan of care. The other thing that we see is multiple pregnancies, sometimes forced or unsafe abortions, continue to be sexually active. There's a risk for future pregnancies and making the same mistakes or the same issues come up over and over again. We see high rates of sexually transmitted illnesses, syphilis, hepatitis B, HIV. We see higher rates in younger victims. We see higher rates of tuberculosis and other infections. When you see individuals who have been recently trafficked, they tend to be very undernourished. The converse is that individuals who have been rescued tend to actually be overnourished, and many use eating or maladaptive eating as compensatory mechanisms. And so a lot of our individuals are obese and have what we call metabolic syndrome, high levels of hypertension, diabetes. We see very high rates of drug addiction. Patients tend to self-medicate themselves in order to try and manage their psychological symptoms. And so when you look at the multiple trauma that our patients have been through, there's really high rates of psychiatric disorders. And then in the background, as manifestation of that trauma, are these really, really high rates of physical complaints, the headaches, back pain, musculoskeletal pain, and of course various sexual health problems. So I wanted to spend some time just talking about the mental health issues, because I think, again, that's a primary driving force how well individuals have a chance to recover. And we see multiple mental health issues arise in our patients. Battered woman syndrome, Stockholm Syndrome, trauma bonds. You might have seen this or heard about this. You can identify with your trafficker or with your kidnapper or the person who's victimizing. Try to form a bond with them in order to get compensatory treatment. We see really high rates of post-traumatic stress disorder. And that's a term that's thrown around a lot. We hear about it in people who've been victims of war, people who are fleeing torture in other countries, but post-traumatic stress disorder really relates to that idea about having anxiety, an uncontrolled anxiety of feeling scared, afraid. They're appropriate when you're threatened, but when you're having them over and over again, they can be very, very maladaptive to your body and have long-term consequences. We see affective disorders, anxiety, depression, panic attacks. We see dissociative disorders, the detachment from yourself, from reality. We see sleep disorders. People can't fall asleep. They can't stay asleep because of nightmares. And of course, you'll also see psychosomatic pain syndromes, chronic pain, fatigue, GI distress, headaches, and dizziness. And very high rates also of self-injurious behaviors, people who cut themselves, who injure themselves to escape. And these rates of these types of problems are significantly increased above and beyond what we see in the general population. So what do our patients look like? Well, the majority are female, and the mean age is about 29 years. And this is actually really important to recognize. Most individuals end up entering trafficking at a fairly young age, 11 for boys and age 12 for girls. But by the time that they're actually rescued and they enter into our care, they're actually much older. And so it takes a long time actually for these individuals to sometimes get into clinical care. The majority are US citizens. Although in South Florida, we do see a significant number of individuals who are non-citizens. The majority of the individuals that we actually have in our clinic right now from sex trafficking have been trafficked for several years. But again, I really want to emphasize that labor trafficking is just as important and just a significant issue here in South Florida. Over 90% of the individuals that we have in our clinic have a history of interpersonal violence, including physical and sexual abuse during childhood. And that's really important to emphasize and realize. The cycle can end up repeating itself over and over and over again. And many of the young individuals who end up being trafficked, they're running away from homes that have significant trauma. Over a third of the individuals who are our patients have kids of their own, and therefore it's really important that we actually stop and make sure that those kids that our trafficking survivors are growing up in safe, protected, nurturing environments. 66% have a history of drug abuse, in many cases, again, as a compensatory mechanism. And of course, the medical problems, the chronic complaints, chronic neck pain, back pain, which run the risk of over-treatment or inadvertent treatment. Pelvic pain, our patients have a high rate needing dental care, of having vision issues. We've seen malignancies. So I wanted to also emphasize that many of the women in our clinic have had babies and have had babies in our care. And it's really important that we make sure that those new lives which are coming into the South Florida community have the best possible chance of having a successful life and having a happy life and thriving. We have transgender individuals in our clinic, need holistic care. That includes hormonal therapy. And in some cases, we want to make sure that we address the disparities of care and make sure again that they are not re-traumatized and don't have these additional barriers. What is the background principle and element that we really focus on for our clinic? It really is what we call trauma-informed care. creating a safe environment, a welcoming environment, giving support and teaching and emotional regulation, and making sure that we build relationships and connectedness. Because we know providing the best possible care to human trafficking survivors. But we're using the key principles that we learned in treating our HIV patients. We're using key principles that we've used in treating domestic violence victims. We're using lessons learned in our veterans who've been through trauma. And we're trying to apply those principles in a multidisciplinary way through our clinic, which has really been designed to offer that patient-centered, one-stop shop care for this unique population. There is certainly the traditional pharmacotherapy in terms of medications, and a lot of times we will actually utilize this upfront, short-term, to help to combat issues like nightmares and so on. We really believe the background is not just or not only, and in some cases not for maintenance pharmacotherapy. And we have to utilize models such as psychotherapy, cognitive behavioral therapy, cognitive processing therapy, narrative therapy. People can tell their stories in a safe and comforting way and not in a way where they're re-traumatized. And we're truly blessed that we have a cohort of behavioral therapists and psychiatrists who really engaged in working with our patients in a longitudinal manner to deliver the best possible treatment that we can. When you look at individuals who've gone through significant trauma in their lives, and that trauma can be many different types. It can be related to gender, it could be related to race, it could be related to significant stigma. HIV individuals who in many cases, again, may have long-term worse outcomes. There's always a danger in labeling those differences, Black, HIV positive, transgender. When we look at health disparities, those differences in outcomes, we can understand that they're not driven by genetics, but in many cases they're driven by in sort of three different levels. Number one is discrimination, biases, and stereotyping. Secondly, it can be the ecology of the healthcare systems and environmental factors. Not having appropriate housing, not having appropriate access to food, not having appropriate access to healthcare. And last but not least is that sometimes differences in outcomes are driven by the culture. And that doesn't mean that we should accept always, right? Those differences that our patient present to us. They might say, you know what, I would never want to be intubated, or I would never want to take this particular medication, or I would never want to be vaccinated. The easy answer is to say, well, that's my patient preference. The challenge is to talk to your patient and listen to the why, and make sure that you answer their questions and still see whether or not you can move them towards optimal care. I wanted to just say again that with Thrive, we have built this interconnected medical home that comprises of primary care with continuity, that provides, again, psychological and psychiatric care with longitudinal. We also utilize outside referrals and resources as needed, but the majority of care, again, is really delivered through primary care, obstetrics and gynecological care, and psychiatric and psychological care. And if you had to pick, right, the majority of our patients' needs, I bet you could guess what that is. It really is psychological and psychiatric care, right? That's what they need more than anything else. Thank you for asking that question. One of the things I'm going to do is really talk about how COVID and this disconnected way in which we've had to deliver care has impacted the care of human trafficking survivors. What we've found is that using interventions such as using telehealth has been a great way to reach out, remain engaged. As it's safe to open up, continue to maintain connectedness. One of the things that we've been very successful actually doing is delivering mental health care via either telephone or, more importantly, via video telehealth mechanism. And in some ways, this actually has improved access to care for some individuals who had difficulty accessing the medical care center, having difficulty with traditional hours because of work or other responsibilities. For many of our patients, there have been more barriers. There have been more barriers through COVID because of loss of housing, food insecurity, job insecurity. If you can't meet the basics of living, food, shelter, Wi-Fi and phone bill may become a luxury. And so for some of our patients, they have not been able to connect by video or telehealth, or they've been out on the street again, or they've been forced into difficult relationships that they've separated from. So this is something actually to what happens when the most vulnerable in our society are presented additional challenges and they don't have that safety net to fall back on. So when we talk about mental health and care, one thing is to diagnose, but another is to treat. COVID-19 has impacted our patients, and it's impacted them in a way that we find challenging to address outside of the medical care system, which are just as important for health. And that's again related to food, it's related to security, it's related to jobs, it's related to housing. These are the core principles upon which health are built, upon which our health systems need to be built to make sure again that we have optimum care for all.
That was Dr. Stephen Symes, and he is the medical care provider for the Thrive program. And our third and final speaker is only a 10-minute wrap-up. Question number 3 is, what should you do if you suspect or witness a trafficking situation? And the motto that we're going with is do not engage, but educate. So if you don't know the trafficking hotline, the number is on your screen, 1-800-373-7888. And, you know, right now, of course, during COVID, we're saying stay safe, stay safe. So stay safe. Do not engage. Do not try to stop anybody or anything. If you could take a picture, maybe with your cell phone, sort of discreetly, that might be helpful for law enforcement. But most likely, a trafficker is armed, and you do not want to be in that situation. But there's the hotline number, and and some of you are still answering question number 2. I'm not going to end the poll just yet, but over here in the chat box, welcome ladies who are joining us from other clubs. We have Sarah from the Cocoa Plum Women's Club, and we have a Monique who is a dependency case manager from St. Lucie County. Hello. I'm so glad more and more people are joining us for these seminars. All right, I'm closing the poll and going to just share our final speaker, and then I am eager to introduce Dr. Potter.
Dr. Corrales, it's been a pleasure and a joy to work with you on developing this national model of healthcare. Your leadership and your wisdom and your experience helped me develop a sustainable program for survivors to improve the lives of all of the victims that we serve. Please talk about ideas about future directions for Thrive and the possibility of replication of this model nationwide.
Thank you so much for inviting me, and being a partner on this journey has been really one of the highlights of my life. I'm a first generation American. And I'm a third generation graduate from the University of Miami. Working with Jonelle has been tremendously important to solve this problem. We started this clinic a while ago, and it's really with Jonelle's leadership that we've gotten this far. You remember that 13-year-old girl you saw in the mall who was dressed a little too provocative for her age, who was hanging around with an older man? Or perhaps you remember that kid on the street corner who looked like he was undernourished, who was pushing drugs, you thought. And maybe that au pair who was in a home that you visited, yelled at by the owner of the home for not cleaning something quickly enough. The good news is they have been taken out of that life. The Thrive Clinic, it's put together a cadre of professionals who truly dedicated to fixing the health needs of these patients. But that's just the beginning. That's the tip of the iceberg. Many years have gone by where they have not had what we would expect: dignity, respect, and a chance really to make a difference for themselves. This trauma has affected them in a significant way that may not be able to be undone at a simple pill or a simple therapeutic intervention or procedure. So really, Thrive tries to address the biological and physiological problems. PTSD is a word we bandy around, but when you look at the actual manifestations of it, PTSD leads to avoidance and numbing. It leads to intrusive memories. It leads to anxiety and emotions because it re-traumatizes them. And so the emotional numbness is their way of protecting themselves. They have flashbacks, they have disturbing dreams, they have intrusive memories and thoughts. And oftentimes they lash out. It could just simply be a work problem, a family problem, an argument, a physical problem. They're not having good sleep, they have low energy. Their thoughts and feelings are constantly negative. They decrease their productivity, their behavior, either it's antisocial or it's withdrawal. Think of yourselves if you had to go look for a job and you didn't have not only the skills, but actually the physical and mental ability to be able to control your emotions. These childhood traumas, this traumatic experience stays with these individuals, which leads to social and emotional impairment. They don't have not only the skills, but also the ability to remember, because they have changes actually in their brain, which makes them more likely to go for overeating or undereating, smoking, drugs. These illnesses often lead to disability, to more social problems, and an early death. There are studies now, and we are part of them, to try and link the trauma with physical illnesses and also to understand how we can change that. We provide health care. How do we do it? We do it through a cadre of individuals who have donated their time and effort to provide the kind of care that we envisioned would be trauma-free. It's the kind of care that essentially doesn't re-traumatize them. It helps them navigate a healthcare system which is huge and often impersonal. If you've ever been to a large hospital, you understand what it's like to try to find your way among consultants and all the laboratories that you have to go. We created a system where a personal navigator works with the patient from the time they come in to the time they leave, helping them make the appointments, keeping the appointments, actually going with them to the specialists, to the pharmacy, and making sure they don't get lost in the system. It's critical to understand that this amount of effort is unique. And as much as all of us want that kind of healthcare system, we realize that our patients could not make it without it. So we've invested in this and make sure that they're engaged with their own health. Healthcare is transforming itself. We no longer are looking at just treating diseases. We really are looking at patients as individuals who need to maintain wellness. So the shift in healthcare, not only with COVID, has been to be much more personal in the kind of care that we have and try to prevent disease. So in our patients with human trafficking, the Thrive Clinic has created a home where you go and there's family there to take care of you. We try very hard to understand what the needs of our patients are and really make a difference in their lives. So that's what's called a comprehensive healthcare system, a medical family home. That's what Thrive is. And in addition, it is at the highest tiers of an academic medical center. We have experts who understand the uniqueness of this particular model to provide trauma-informed care. And that's really what it's all about. It's all about maintaining this model and make a difference in the lives of these patients. It takes people who understand housing, who understand food insecurity, who understand how to help somebody get a job when they've never, ever really had a job. One of the programs that Thrive has is something called a peer program, a peer support program, where we actually bring in people who have survived, have made a difference in their lives, and are willing to come back and help others. We actually hire these people, and we hope that we can provide a model for the rest of the country. Thrive is an innovative program, and we're now embarking on the next generation, if you will, of healthcare delivery, which is telehealth. Thrive has been successful primarily because of the innovations and ability of our founder, Dr. Potter, and all of the people who work in the program to be able to put together competitive grants that fund us. This is not an easy process. We are donating time. Jackson Memorial, the University of Miami, all of these hospitals that have supported us, the state attorney's office, have allowed us to continue our work through their generosity. I don't know if you've noticed, but healthcare is a business. It will take not only a village, but an entire community to really, really break the back of human trafficking. Human trafficking is the second largest illegal trade behind drugs and ahead of guns. So it's a business for these traffickers. They're making money off of these human slaves. They're very creative, okay? We need to be equally creative to break the back of human trafficking. We have to look to their futures. We have to build for them an opportunity so that they never go back to trafficking, so they never let anyone else go back to trafficking. It is so important that all of us come together as a community, make a difference, speak up, change their lives so that they never ever go back and they never let anyone else go through what they went through. Thank you.
I'd like to thank the Women's Club of Coconut Grove allowing us the opportunity to come and speak to you today to talk about our innovative model of healthcare for human trafficking survivors, Thrive. This is an extraordinary opportunity for us to share our knowledge and disseminate our information to the community. And we ask each of you to take the stories that you've heard today from all of us and share them with your friends and your colleagues and get the word out so that you can help us all end human trafficking in South Florida, this country, and worldwide. Thank you very much.
All right, ladies and gentlemen, I'm going to give the podium over to Dr. Potter.
Hello, everyone. Thank you very much for taking the time to listen to our talk today. This talk was produced with a lot of hard work by Travis, and we so appreciate him and all of the work that he put in to making sure that the video came across as well as it did. So I'm here now I'm happy to answer questions. Travis, how will it work? Can I hear them? Or will they put questions in the chat?
It might be in the chat or in the Q&A. There was a question that I got on my cell phone, and what can you, us as a club, what is the best way that we could support your cause of ending human trafficking?
Human trafficking exists like any business exists because there's a demand for services, right? So Catherine Rundle, the state attorney, passed legislation last legislative session so that someone who's buying sex from a child, for example, if they're arrested for the crime, their picture is going on a billboard. So part of the problem with sex trafficking is there's supply and demand. There are people in our community that pay big money to have sex with our children. So getting that message out and ending sex trafficking in South Florida and making it unacceptable and making sure that people understand if they do get caught and they do get arrested, their picture is going on a billboard on US 1 is a very important message to share. And the same with labor trafficking. We have such a big problem in our community with labor trafficking, domestics, people that are brought in to help their families back home in other countries. And they come here to work, and they work really, really hard, and they're not paid a fair wage, and they're not compensated, and their documents are taken, and then they're threatened. We've had some examples where the trafficker goes to the hometown and photographs the family, and then, or has a friend in another place photograph the family, and then shows the victim the picture and says, if you don't do what I tell you to do, I'm going to kill all of your family back home. I mean, I have terrible stories. If there's something that you want to do, the most important, the reason why I'm here today is to bring awareness, because if there wasn't a need and a demand for service, it would end. If everybody felt and believed that people should be paid for their work, labor trafficking would be addressed. If everybody understood about sex trafficking and that most of the victims are taken as young children, either kidnapped or they run away from a bad situation and walk right into another terrible situation. Many of the victims come from bad foster care programs. They're not all bad. We're doing better, but it's still a situation of abuse during childhood. Almost all of our patients had childhood sexual abuse as one of the issues that they experienced that they report on their history. So I would say starting there.
Do you know how many cases there are in Miami-Dade?
No. No. So Catherine Rundle keeps statistics. How it works in Miami-Dade County, we have so many cases. We have a local human trafficking task force, and then we have a federal human trafficking task force, Homeland Security. So, and that's because the cases are either prosecuted by the feds, the federal prosecutor, or state and local law enforcement. And it depends on the crime and what, if it's a state involved crime or if it crosses the border, if it's a domestic or international crime. But we have so much work that it keeps both the state and local and federal prosecutors working on these cases. And so I have data from Catherine Rundle's office where they've processed cases where they've arrested the trafficker and brought the trafficker to court. And they're up in close to 1,000 cases just in South Florida. And these are cases that they actually worked the case. So our numbers are extraordinary. We're second or third, but they're only the cases that we know about. We have multiple law enforcement police stations. You know, Doral, Miami-Dade, Coral Gables, they all have their own units. And what we have done in South Florida, and we're very progressive, is we train as many law enforcement as we can so that everybody in every police station is aware of what a victim may look like and what to do if they see one. The same how we just tried to explain to you. And the beauty of law enforcement here is we try not to use the victim as a reliable source in the prosecution. They're very creative, and they're nationally known for this. They go after the other crimes. money laundering, wiretapping, so that the victim is not re-traumatized by being allowed to be deposed by the trafficker's lawyer, et cetera, et cetera. So there's so much to talk about in terms of law enforcement and numbers, but very underreported. How do you address living and/or food insecurity? So that is a huge problem in South Florida. You know, the Homeless Trust really manages housing for our homeless population, and there just are not enough beds to address our homeless population. We have 2 resources, but there's many, many more. So there's housing for and programs like Christie House, Project Gold, Citrus. These are all wonderful programs for children that are 18 and younger. And what we found when we started Thrive is that there weren't a lot of resources for adults or men or boys. So we have Lotus House. I don't know if any of you are, hopefully many of you are familiar with Lotus House. It's a 500-bed facility for women and children, and it is an amazing place, and I encourage all of you to look at it. But those beds are available through the Homeless Trust. So care is not free, even in a homeless shelter. And it's basically about $50 a day per day for supplies and for a patient to be there. So it's about $1,800 a year, $3,600 for 2 years, but they can stay, they can bring their children, and they have health care there, they have child care there, they have opportunities for them to learn how to be hairdressers or culinary arts. So it's an amazing place in Overtown. The other place that we have, which is immediate shelter, so when a victim is identified, they're pulled off the street, the trafficker goes to jail, the victim goes to the victim evaluation center, which is near the state attorney's office, which is like an intake place, so they don't have to go to the police station. And then they're brought to Phoenix, which is a program that Catherine Rundle was able to get state funding. And it is a unit in Camilla's house that's dedicated to care and treatment for survivors, all females, for human trafficking. So those are our 2 resources, but they're short-term, they're transitional. Housing is one of our greatest needs. You know, think about food insecurity and how expensive it is to eat and to have food. And many of these victims that were taken when they were young, they never learned how to cook. And they've been fed horrible diets for 10, 20 years, fast food, 1 meal a day. So there's tremendous work in those areas as well, and part of their recovery and what we work with them on. How can we support Thrive directly? We, at the University of Miami, we have an account for Thrive, because through when you do your United Way internally, people can donate. So we could take donations to the Thrive program through the University of Miami, my department, and I can type that in the chat box. And what we do with that money, we've had a couple churches who have made donations, is some patients that are in shelter, they need over-the-counter meds, right? So they'll need Advil, or they'll need personal hygiene items, or we have a social worker who works with them. So that Carlos Magoya is a hometown champion when it comes to the Thrive Clinic, and he gives us space at Jackson for free. It's you think that Jackson is Public Health Trust and the place for but it's not free. You have to get credit and classification, financially classified. And so our deal is that he gives us charity care with true human trafficking survivors. And then over time, our social worker tries to get them Medicaid or insurance, because they need about 2 years of care. And some of their care is very comprehensive. And so we get them on Medicaid. And then, as most plans are, there's copays. So if we have to see the patient for mental health and they have a laboratory visit, each one of those visits has a copay of $20 or a copay of $30. So they have insurance, but there's still a cost. And our survivors are not in high-paying jobs. So if they're working in a restaurant or they're working in a dry cleaner, the co-pays for one day is sometimes 2 days of pay. So then they don't come back to the visit because they can't afford it. So we use our philanthropic funds to help cover the co-pays or incidental items. We have a training program. We have a volunteer, Diane De La Orza, who is an amazing community advocate who reached out to us to see how she could help. She has a history of being a director of case management in the community. She's a nurse, and she wrote this incredible curriculum because many of the survivors that we see, after they're with us for a while, they want to be a nurse's aide, they want to be a medical assistant, they want to be a patient navigator, but they need training and they need education. And so we thought, what a great idea to do like an internship, a curriculum and an internship. We've had 22 women who have had babies, so we would like to train people to be doulas and supportive. Remember what Dr. Symes and Dr. Corrales said, we want to make sure that there's parenting support and help them raise and nurture their children. And our patients, some of them are interested in healthcare. So Diane developed a curriculum that's very intensive, it's very involved, it's really perfect, but it costs money to run. We have to hire people to run it, and we have to pay the survivors an hourly stipend so that they would be working during training, kind of like an internship. And so if there's anybody who knows anybody that wants to donate to that program, that we've got some money from the churches, but it's not enough to even launch the program. So that's an opportunity for direct funding that would really bring job training in healthcare to support the Thrive model. I hope that answers the question.
Do you want to put that information on the...
So I'm going to put my email address. That's the best way to do it. And if you're interested in reaching out to me, or you have questions, or you want to make a donation, I can send you the link, and that would be wonderful for our patients. And if anybody has a building, you know, Glory House is a wonderful example. We had Glory House for a while. It was a 2-bedroom, twin beds, a place where, you know, 4 people could live and stay, and they had a lot of support and mentoring to like re-engineer and rebuild their lives. So I don't see any more questions, Travis. It's been a wonderful honor to speak with all of you. I hope that this has been a valuable hour and a bit for most of you who have joined the call, and I look forward to my emails there. I look forward to hearing from all of you. Have a wonderful day. Here's Travis.
Thank you, Dr. Potter. I don't know if we mentioned, but January is National Human Trafficking Awareness Month, and we are so glad that we could put this program together for you. Be looking forward to seeing everybody +1 at our speaker series next month. We are doing something very creative for Black History Month. I'm really glad I have something to do. I've given myself so much to do. I want to remind everybody also, next month is our anniversary. So please be looking for Madam President's emails and announcements about what you can do to help and what we're going to be doing. And hopefully we see more and more of you virtually, staying safe, staying healthy. Thank you so much, everyone. I'm so glad you can join us today, and I'll talk to you later. Bye-bye.